for joining today's webinar on social determinants of health, data strategy, and population health. I'm Gabriela Gonzalez, a program manager at Chicanis. Please note that Azara Healthcare will be presenting today on the social determinants of health module, its tools and functionality in the Drives platform. As some of you were with us last week webinar content covered promising practices to strategize the collection of social determinants of health. It highlighted that a standardized and a systematic approach for collecting social risk data enables health centers to transform their practices in order to gain a comprehensive insight into patient population and their unique social needs. Today's webinar will continue the quest of this work by exploring how health centers might enhance their internal processes and tools in order to use social risk data in a meaningful way. Again, thank you for coming to today's webinar, and thank you for your participation. Let's start with some housekeeping items. Please note the phones have been muted to prevent background noise. You can use the chat box to type questions throughout the webinar. Please note that questions will be answered towards the end. We welcome your feedback, so as you go along, you can type those in the chat box. This webinar is being recorded, and soon it will be available for download on the Chicanis website. A webinar evaluation survey will be shared with all participants. It should only take about 2 to 3 minutes to complete. We really appreciate your feedback and hope you are able to complete the survey post this webinar. Some additional housekeeping items. Last week, it was announced that due to the high interest on this Social Determinants of Health webinar series, the New York State Health Center Control Network is offering office hours to community health centers. You can sign up for office hours to ask any post-webinar questions. I encourage you to take advantage of this opportunity. You can use a registration link to sign up for either Tuesday, November 26th from 1 to 2 p.m. or Monday, December 2nd from 10 to 11 a.m. Those will be held via Zoom. Additionally, as part of the New York Statewide Health Center Control Network, in 2020, Chicanis will facilitate a small learning collaborative. This learning collaborative will be made up of 4 to 6 community health centers that will work together with a Chicanis program facilitator, in this case myself, to work on post-social determinants of health implementation workflows and frequently asked questions. Additionally, individual training and technical support will be available for community health centers. These opportunities are in a first-come, first-served basis. Please complete today's webinar to express your interest. You can also email me if you have questions or concerns about today's announcements. Okay. So as mentioned earlier, today's webinar is focused on building a social determinants of health data strategy that will inform patient-level and population-level care delivery. You will learn more about the Center for Primary Care Informatics, referred as CPCI, and its social determinants of health modules functionality and capabilities. CPCI is a robust cloud-based data reporting and analytics solution, and it's one of the drivers of performance improvement for a majority of community health centers in New York State. The ability to perform data analysis and reporting is essential for organizations to manage the health of their patients, enhance their capacity to make more evidence-based and data-driven decisions. If your organization is currently not connected to the CPCI Drives platform, you might still find this presentation relevant and applicable to your work. Without further ado, I would like to introduce our guest speaker today, a representative from Azara Healthcare, Emily. I'm going to stop sharing and you can take it away.
Great, thanks, Gabrielle. All right. And Gabrielle, can you confirm that you can see my screen?
Yes, we can see it. Thank you.
Great. Well, thank you so much for that introduction. As Gabriella said, my name is Emily Holtzman, and I am from Azara Healthcare, and today I'm going to be talking about social determinants of health, leveraging CPCI tools to drive patient care. So we're going to be doing a little bit of a background about Azara's approach to social determinants of health, some of the tools that we've created in our program or in our application for you to use to evaluate your efforts in both collecting social determinants of health and also talk about some use cases for how you can use it to drive improved outcomes and outreach to different patients. I just want to put an announcement out there. We are having our annual user conference technically in 2020, March 30th to April 1st. It will be in Boston. For anybody who is interested in attending or interested in submitting an abstract to be a speaker at the conference, please feel free to reach out to me. My contact information is at the end of the slide, and we would love to see you there. Right. So as I said, we'll be starting off talking about the context of social determinants of health, running through a little bit of how you collect and store SDOH data. I'm not going to spend a huge amount of time on that because I know that the previous webinar in this series did cover that topic. And then we're going to spend the bulk of the time talking about reporting and analyzing social determinants of health data. So assuming you get up and running, you have a tool, you map all of that information into CPCI, how are you actually going to use it to generate lists of patients for outreach, for targeted interventions, for different teams at your health center to get engaged with them in a different way? So we're going to spend most of the time talking about that. And then finally, a little bit about what our plans are from a product perspective to bring you even more tools for reporting and analytics. So if we think about what are social determinants of health, just before we get started, they really are the determinants of health in which people are born, they grow, they live, they work, and they age. So everything that's happening outside of the health center about the way that people live their lives, and this can be found in social support networks, what's their job, what's their education level, what does their physical environment look like. And if we think about that and relate it to the ability to care for patients or to impact some of these factors that we have at the health center, the vast majority of what's determining a patient's health or how their health outcomes are going to go throughout their life are really not determined in the office of a physician. And I know that everybody on the phone here who is involved with community health centers and who has worked in FQHCs, probably a lot of you for a very long time, is intimately aware that the patients that you see are very strongly impacted by a lot of these social determinants of health factors. And a lot of it are factors that are hard to address in the doctor's office or require additional supports that are not necessarily what you strictly think of as traditional conversation between a physician and a patient who comes in. So as we think about our shift from fee-for-service to fee-for-value and this model that we're all very familiar with and the direction that healthcare is going, you need to start thinking about how are you going to move some of your efforts upstream to have an impact on these social determinants of health that you may not have traditionally addressed or that you feel like you have limited resources. So our goal with the tools that we've come up with in Azara is to help you identify patients who could really benefit from earlier interventions or moving some of your efforts with those patients upstream. So getting them connected with community resources, identifying if there's a food security issue, because as you can all imagine, those dramatically impact health outcomes that are captured in a lot of clinical quality measures for which you have to report on. So something like if a patient is food insecure and they're trying to manage their A1C because they're diabetic, that's going to be really hard to do and address solely in the doctor's office when they come in for a visit. So when we were thinking at Azara about how are we going to build this out, how are we going to give all of the folks who use our system good information to help them move some of that work upstream and help them address all those factors that are happening outside of the clinic, we decided that we really needed to define and document increasingly complex patients. And so what were the structured data elements that we're going to be able to use to do that? This would enable the folks who use our system to better target clinical care, loop in enabling services, community partnerships, and help see if that's going to be making an impact down the line on their patient populations, as well as enabling centers to really demonstrate the work that they're doing. So our analytics products, while they help you see the snapshot of where you are right now, they are also designed to help you see the transformation that you've made and the changes that you've made across your population in the long term, not just in the short term. So sorry, I think the slideshow got a little ahead of itself. So the prepare elements that we use, and Gabriella spent a lot of time talking about this on the last webinar series, but we base all of the analytics that we do in CPCI off of prepare. So we use that as our template. We do not exclusively require every center to be using the prepare template. However, we do require that whatever template or questionnaire you use, it roughly aligns with the questions that prepare asks, because those are the standard drive data elements that we use in our system. So we capture personal characteristics, including race, ethnicity, language, veteran, refugees. You'll be very familiar with these. They're required by UDS to capture them. So chances are those are getting captured in your EHR somewhere, not requiring a special SDOH template or a prepare template. The next sort of layer, though, is material securities, including things like food, utilities, phone, housing and income, insurance. Again, a lot of these are going to be very familiar, and you may already capture them in your EHR and structured fields without even having a social determinants of health questionnaire. And then once you move into the situational characteristics like safety, domestic violence, transportation, isolation, those tend to be less available just in the EHR without actually having purchased a specific template or having a workflow built in to capture that information. So what we focus on mainly in the specific social determinants of health module that we offer in Drives are what we call impactable elements. So those are things like material security and situational characteristics. So if you think about it, if we go back here, you at your health center are not going to be able to change someone's race, ethnicity. You could maybe offer classes for language in English potentially, but again, these are more characteristics of a patient that you're not necessarily going to be focusing your time on because they're not things that you can change. Whereas material security and situational characteristics, sorry, it keeps doing that, those are things that you could possibly connect patients with in the community. So this group of impactable elements is what we tend to focus on most when we start talking about the actual tools that are in the CPCI that let you go through and see the percentage breakdown of your population that's impacted by these different elements. So as we move into collecting and storing SDOH data, so we've covered kind of our background about what our methodology is. This is a good broad overview of how we think about the journey to actually getting your data. And this is a simplistic overview, but the steps are still very helpful to familiarize yourself with. First, you need to choose a survey tool. The majority of our clients use Prepare, and it's probably the easiest one for us to map because that's the standardized drive values from which we draw for our tool. However, again, if you have a different template, as long as you're asking questions that are similar to Prepare, so Prepare has specific wording around food security, but if your template has a food security question and we can map that to the food security SDOH item that we have in CPCI, great, we can absolutely do that for you. After you've chosen your survey tool, you need to create and use the EHR templates available. So typically, you'll have to purchase that from your EHR. They might implement it already. They might have it available for you. It really depends on which EHR you're using, but you'll need to actually have that appear in your EHR so that your users can access it. The next step is really, really important that you define workflows required to capture the SDOH data. So obviously, even if you have the greatest template in the world, if people don't know where to find it and they're not actually bringing it up when they check a patient in, or they're not screening the patients that they're supposed to be screening, you're not going to get any data. And even if you do get data, it won't be reliable. So it's very helpful, you know, this step is down here, but I really think it should be considered as you go through even the beginning part of the process. So what we see with a lot of our clients is that screening every single patient who walks in the door for SDOH factors using the Prepare template is just not realistic. It's a fairly lengthy questionnaire, takes a long time to fill out, and, you know, center leadership says, you know, we don't have time to do that for everyone. So maybe we're going to start out by doing the SDOH assessment for patients who meet certain criteria. So some of what we would maybe consider are higher risk patients, whether that's using the risk algorithm in Azara or a different risk algorithm. But we're only going to target a specific group, and then we're going to expand beyond that when we feel like we have a better handle on the tool or we have better, more defined workflows around it. After you start to capture this SDOH data, you need to map and validate it. So if you're planning to use it in CPCI, we need to do what's called mapping, where we take the standard values from your EHR and we tell CPCI what those values equal in our standard Azara Drives terminology. That's what allows you to do the analytics in the tool itself. This is a project that's done with our implementation team. If you're a newer center and you're just going live, you can wrap this into your initial implementation of CPCI. Otherwise, you really just reach out, you enter a ticket, and then we get somebody to help you go in and figure out where that information is captured in your EHR. And then we get to this part, which we're going to spend a bunch of time talking about today. How do you actually use that data? Once it's all in there, once you have people collecting, they're asking patients these questions, how do you make good use of that data? This is an example of a crosswalk. So again, we use the Prepare questions, and we just showed here some of the common templates that we see people use and what kind of questions are available in each of the templates. So if we look at the food example, Prepare asks, in the past year, have you or family members you live with been unable to get any of the food when it was really needed? The answer is yes or no. We would map this to an SDOH factor of food. And then if the answer was yes, we would consider that patient to have we would consider them to fall into the bucket of food insecurity for SDOH factors, and we'll show you how that looks on an actual dashboard. If you have another template that asks something similar to this and is a yes-no question, or something that you can easily identify as positive or negative, again, we can absolutely map that too. As with any change that you implement in CPCI, we require that validation be done, because if you can't trust the data that you're looking at, it's not going to serve you very well. So some key rules that we always talk about is when you start using a new template or you begin collecting social determinants of health from an assessment, really involve clinical staff in the validation effort. They're the ones who know the charts really well. They're the ones who know the patients and can provide really valuable input on what it should be looking like. You need to have sufficient data, so before you can start validating, you need to have at least 30 patients who you've actually asked the social determinants of health assessment to and who have data in CPCI, so then you can compare it to the actual template in your EHR. If you have a list of patients who already have had their social determinants of health documented, then you can go back and say, okay, they answered yes in the EHR, and yes, this patient is showing up as having food insecurity in CPCI. So then you can just do the direct comparison, make sure everything's flowing over correctly. You also want to check things like the completed date. So when was the assessment completed? Is that reflected correctly in the registry that you will have available in CPCI? And make sure that all of those factors are accurately represented, that you're not missing something that's maybe in a different format or is filled out differently than you originally thought. All right, so now if we start to get into reporting and analyzing social determinants of health data in CPCI, what does that look like? What are the different tools that we have available for us? So before we jump into that, we have a poll question, which Gabriella is going to launch. So this is going to ask, what tools have you used to view social determinants of health data in CPCI? Please select all that apply. And obviously there is a choice too for, I do not have SDOH data in CPCI yet for my center.
Yes, so we're going to give folks about, I would say 40 seconds or so they can read over the option. As you mentioned, it's really meant to assess what functionalities or tools are you currently using related to social determinants of health in CPCI. All right, so we have 29% of the participants have voted, so let's wait until we get that percentage to at least 50 or 60, and I'll close the poll. Okay, we have given participants about a minute, a little over a minute. It's close to 50%. I'm going to share the results with everyone. So we have a few variations. 39% of the participants today do not have the social determinants of health data module for in CPCI. 22% have not used any of the above functionality. 22% have used all of the above functionality. And in terms of each tool or dashboard, patient visit planning report, it's the most utilized, followed by registries, and scorecards and dashboards are together at 9%. So we have a good mix.
Great. And I can actually see this, Gabriella, which is great. I didn't know if I would be able to. And I want to make a couple comments on that. Thank you all for submitting your answers. I think for those who answered, I do not have SDOH data in CPCI yet for my center. This is, if you are interested in this module, you can enter a support ticket. You can reach out to me if you would like a demo of what it looks like. I mean, we're going to cover a lot of what the functionality looks like today. But I would say that if social determinants of health is something that you're interested in, it really makes sense to start doing it sooner rather than later, both in terms of planning how you're going to roll out the assessment tool that you're going to be using at your center, as well as getting that data in there. The sooner you have data available for you to see how efficient and effective are we in asking this to our population, the easier it's going to be to make tweaks down the line and make use of this information. I think a lot of people sort of think of SDOH sometimes as still a buzzword or something that people keep talking about, but nobody really knows what to do with the data. And it is, using this kind of data is still a newer concept, but it is very important, particularly for the populations that FQHCs serve, to start to examine this. And I really think having as much data as possible from the beginning is a great way to do that. For those who have SDOH data mapped in CPCI but have not yet used any of the features, I really hope that this webinar today will help spark your imagination and hopefully give you some ideas about where you can go, how you can start using some of the tools, as well as there's a lot of information available in the health section of Drives that can help you as well. I'm also really glad to hear that some people are already using all of the above and at least some of the other features. So we're going to go through all of them today, and we're going to have time for questions at the end too. All right, thank you guys. So this is kind of your roadmap of where everything is available to you in CPCI. So first of all, we have an SDOH registry. So this is going to show you all of your patients who have been given a assessment tool, whether it's Prepare or something else. It will show you some of the core registry columns that we always have available in all of our registries. So for those who are more familiar with CPCI and you've used registries before, you'll definitely recognize the usual provider, next appointment time, basic demographic data. But we will also show you all the different social determinants categories and the date that it was recorded that patients screened positive for them, as well as we'll show you raw EHR responses, so you can see what that looks like when you actually filled out the assessment. And here, the beauty of this is it's a lot of really granular information about an individual patient, but you can also filter and sort. So if you want to see a complete list of patients with demographic information, with provider information, you can sort and see everybody who is food insecure, for example, and I'm going to show you that in just a minute. We also have the patient visit planning report and the care management passport, both of which will show you SDOH factors on them. So you'll see that there's a left-hand side on the patient visit planning report, and you'll be able to see all of a patient's social determinants of health factors, as well as on the care management passport. We also have an SDOH dashboard, which will break down sort of where's the status of your population in terms of who has been asked or assessed for social determinants of health factors, and it will also show what's the breakdown of that population. So what percentage of them have stress, what percentage of them are transportation insecure, things like that. And then finally, we have the SDOH filter. So this is available on a wide variety of reports and measures and registries throughout Drive. And this is where you can filter whatever report or registry or measure analyzer you're on by a certain social determinants of health factor. And this is really helpful for kind of that more ad hoc analysis. If you're looking at performance on a measure and all of a sudden you want to know, well, everybody who is food insecure, how are they doing on the A1C greater than 9 or untested measure? And that might be really important information to have to start thinking about how do we want to alter our program to help improve this measure overall and also help address this social determinant of health need. This is a nice little piece of background just illustrating how different comorbidities and social determinants of health or different diagnoses or risk factors, however you want to think of it, are typically correlated to social determinants of health. And it's just reinforcing that those outside factors that are not seen in the doctor's office necessarily have a really dramatic impact on patients' health. So you can see here that basically the higher the number of patients or the percent of patients with hypertension, the more social determinants of health factors they typically have. And then this sort of drops off here at the end, but you can see it's a pretty steadily curve that's going up. And you can see at the peak here, you know, over 40% of patients have, you know, a correspondingly large number of social determinants of health factors, whereas those at the bottom, that's a smaller percentage of the population. So you can see this also using the filters across CPCI. You can see really quickly, if you start doing your own filtering and analysis, where those numbers are lying within your own population. So we have two different kinds of filters in Drive that help you, well, it's two options for a filter that help you see what social determinants of health factors and the overall tally of the number of factors. So I'm going to go to this next one, because this is a really helpful visual. So basically, we have the tally, which is counting up how many factors were patients positive for. So we kind of use really high numbers as a proxy for patients who are probably a lot more complex and who probably need a lot more intervention. So if somebody is housing insecure, food insecure, transportation insecure, they're a veteran, migrant, et cetera, that's probably going to overall contribute to them being a higher cost, more needy patient. You know, there are always exceptions to these rules, but that's a good way of approximating somebody who might be quote-unquote higher risk. We also have the specific SDOH factors that are available in the drop-down. So if you only want to see somebody who's clothing insecure, you can select that from the drop-down list. It's important to remember that if you're not asking all of these questions, if you don't ask about clothing insecurity or you don't record it and you filter on this, you might get a 0, and that's not because nobody is clothing insecure, but it might be because you're not actually asking that question. So it's important to understand how to use the dashboard, which I'll show you in just a second, to evaluate what you're actually asking, as well as be familiar with what's on your social determinants of health assessment and how are people expected to use that. So a note about how these filters work. All of our filters and drives work as an and across the top. So if we think about any filters you select, not just the social determinants of health one, if you filter to a specific provider, if you filter to a period type, and you filter to a financial class, we're saying that patients need to meet all of those criteria in order to show up in the data that you're looking at. And normally, for most of our filters, when you select within a filter in the drop-down, you're picking an or. So normally, if you picked a provider, multiple providers from the drop-down, it would be provider X or provider Y or provider Z that the patient has seen. With social determinants of health, it works as an and, because we're trying to find people who meet multiple categories. And if you think about it kind of like comorbidities, so what we're looking at is people who have both food and utility insecurity, if I were to check off both of those. Now, one thing to note is that in the tally, that's not how that's working, because as you can imagine, somebody can't have both 4 factors and 5 factors. They have, or they can't be within both ranges for these. So this is going to work as an or as well. So you would really pick this if you wanted to get a full range. So anybody who met, who was at 4 factors to 9 factors. And if you think about it really as we're trying to find people who have a lot going on at once, this and really starts to make sense. This is a great screenshot for how to access the filters. So if you think back to here, if you click on this blue filter icon button, you'll see a drop-down, and then you can add both SDOH and SDOH count. And again, SDOH are going to be the actual factors, clothing, the transportation, and SDOH count is going to be the number of factors that a patient has. So, screenshot of both of those. So now some examples of how you might use this when we think about the measure analyzer. So what we're looking at here right now is A1C greater than 9 or untested. So in this example, this is at 32%. Then if we go to the graph below the measure analyzer, so the comparison table, you've seen here, we're grouping by social determinants of health. And what we're saying now is we're saying all patients who have an A1C greater than 9 or untested, how are they performing grouped by different social determinants of health factors? So if we look specifically at food here, we can see that 34% of patients with food insecurity have an A1C that's greater than 9 or untested, which is 2% worse than the general population. And if we think about it, it's not really that surprising. It's much harder to control your A1C levels if you don't have access to food regularly or if you can't cook healthier meals for yourself. And it's important to know the order in which that we're applying these filters here. So we're looking at, if we've grouped by SDOH, we're looking at your population across your entire population, breaking it down by social determinants of health, and then looking at those who have an A1C that's greater than 9 or untested. We can also do this by SDOH count, so rather than the actual factor, we can see which count bracket has the highest levels of A1Cs greater than 9 or untested, and unsurprisingly, those with 19 SDOH factors, it's pretty unsurprising. This is probably just one patient here, but it's unsurprising that they probably have an A1C that's out of control because they have so many other positive social determinants of health factors. But the way that we usually see this used is to kind of break down and start to think about where should I focus my efforts. So if we look back here, you know, incarcerated, this is a pretty high breakdown, but maybe I just want to focus on the chunk of patients. If I'm trying to improve A1C greater than 9 or untested, or I have a diabetes education program or a diabetic outreach program, who am I going to focus on the most to try and get them the supports they need to get their A1C under control? And so this can be a nice way to sort of put that in perspective and understand where am I even going to start, because maybe it's not the folks who have the employment and the housing that are the biggest issues when it comes to A1C greater than 9 or untested. Always important. It's not like that factor is helping any, but you might want to focus on community resources that can address those SDOH factors that have higher percentages. Next, we have the diabetes dashboard on which you can apply an SDOH filter. So if you want, yet again, another slice or view into your social determinants of health performance on specific measures, we have the stock diabetes dashboard available to you, and you can filter the whole thing by food. So you can see, you know, how many patients with diabetes also have food insecurity. What is my trend line for A1C greater than 9 or untested over time? What percentage of my controlled diabetics are food insecure? As many of you replied on the poll question, social determinants of health are available on the PVP, both as an alert. So if you want to set up an alert to trigger when a patient comes in and has not been assessed for social determinants of health in the past year, you can put that on there as a reminder to your support staff, to your providers, to your care coordinators, whomever is looking at the PVP, that you need to do another assessment. And then we'll also list all of their social determinants of health factors here on this left-hand side. You must turn on this alert in the alert administration. So if you're not seeing it, it's possible that it's not turned on yet, so you will need to enable it. It is configurable, so if you wanted to trigger every 6 months instead of every year, you can do that. If you wanted to trigger every 2 years, you can do that. And one thing to note too, we only show up to a maximum of 10 different SDOH factors here. Because, oh, excuse me, that's not correct. We'll show as many as there are available. I was thinking of diagnoses on the CMP. And then this will give you the number of factors. Here it is again on the Care Management Passport. Looks very similar to how it was on the PVP. This is your social determinants of health registry. I spoke about this a little bit before, but this gives you the social needs assessment date. The social needs assessment completed by, I included this screenshot because I wanted to talk about it. This is actually getting updated. This is no longer going to say completed by. This is going to be the mode by which it was completed. So we're in the process of making that update right now, and it's going to say something like phone, email, in-person, etc. So it's not going to have two different dates here. It's going to have the date, the most recent date that the assessment was done, and then the format of the assessment. We list out the social determinants of health triggers. So this is going to list all of them that this patient screened positive for, the number, and then if you keep scrolling across in all of the different columns, it's going to list out each and every one and what the response was, if there was a response. this is a close-up of how you can use filters to start to hone in on those patients that you specifically care about. So if you're working specifically with diabetic patients who are homeless and food insecure, you can absolutely do that on a registry, and you can apply those filters to get a really targeted list for whatever work you're going to do that day, or you're going to distribute to your team, however you choose to use that. And that's really the beauty of registries. You can use filters in as many ways as you want to focus in on the group of patients that you are going to be addressing for whatever time frame you need it to be. Here's the social needs assessed dashboard. So this is kind of the greatest resource you have to get a population health view of how social determinants of health have been implemented at your center. So the first widget here is what is the overall percentage of patients who have had their social needs assessed. So if we look at this particular dashboard, this is across all of Chicanes. So this is the actual data that's in CBCI right now. So about 2% of all the patients that had a visit to a health center in the Chicanes network in trailing year October 2019, so in the 12 months previous to October, about 2% of them were assessed for social determinants of health. These are the raw numbers. Looks like the trend line has been pretty steady over time. And then we move into the more specific. So these two widgets are specifically looking at, out of the whole population, who has been assessed for social determinants of health. And again, you can run this for your own center. So this isn't just for the PCA view. If you run it for your center, it's going to tell you what percentage of your population that has been for a visit at your center has been assessed. But then the rest of the widgets are only looking at those patients who were assessed. So we can see trailing year October 2019, that's around 22,000 patients. Of those 22,000 patients, 42% of them had the Core Plus One assessed, which really means, let's see if I have it here. Great, I do. So Core Plus One means that you assess the patients about their housing, their food, their transportation, their utilities, and at least one other SDOH factor. And we use this as a proxy to understand, are you getting even close to a complete picture of what Prepare is looking for? And again, we understand that a lot of centers don't have the time to ask a really complete or the entire Prepare template or the entire whatever social determinants of health template you use. So we want to see, do you have some of these quote-unquote core elements that you're at least asking them? And then we're considering, for the purpose of analytics in CPCI, that to be kind of a complete assessment, because it gives you at least a starting point, and it gives you a lot more information than just what's required from the UES reporting. So across Chicanes, of those around 22,000 patients, 42% of them have been asked that Core Plus One. And then all of these widgets showing a breakdown are, again, based on that 22,000 number. So of those 22,000, looks like 12,000 of them, a little over 12,000, scored positive for federal poverty, less than 200, homelessness, housing, and then personal characteristics. And then we've broken them into like buckets so you can kind of view things together. And again, this is just based on those who have actually been assessed. So it's not saying that out of your entire population that's ever been to a community health center in the Chicanes network, only 704 of them are food insecure, because I think, that would be pretty unrealistic. So there's not everybody who's been assessed. The other thing to note is that a nuance of this dashboard, not everybody has been assessed for certain things. So the phone number might be deflated a little bit because not everybody who we're considering complete as a Core Plus One has asked about phone. So this is not to make you distrust this dashboard at all. The reason I'm explaining this is so that you understand the nuance and you understand how to use it going forward. SDOH, reporting and analytics, is really hard, and we think this is a really great jumping off point for you to start to understand your population a little bit better. You also have the factors broken out, and then we have a pie chart listing, what's the percentage that have the certain number of factors, which again is kind of a proxy for how complex are they. Here's some blow-ups of what the different widgets look like, the trend lines. You can also group by different locations. So if you're an individual center user and you're going here and you want to group by locations, you can certainly do that and see the trend line and whether different locations are performing differently on how many of the assessments they're doing. There's another blow-up. So we have another poll question. I know we're running a little bit short on time. I just have a little bit left, but we would love to ask everybody to provide some information regarding your process for managing internal and external patient referrals and how you are tracking that.
Yes, thank you, Emily. So we do have a question just to get a sense, a pulse check of how organizations are doing when it comes to community referrals. So some of the options are, yes, my organization is documenting internal and external referrals in a structured EHR field. And you can select all that apply. Or yes, my organization is documenting internal and external referrals using free text in the EHR. No, my organization does not make referrals to community-based organizations to address social needs. Or the last option is my organization is currently planning external referrals to community-based organizations focused on social risk. So you're looking into proposing a partnership. It would be great to get a sense of what your current efforts are. So give people a few more seconds. 25% of the participants have answered. Let's hope to get up to 50, and I'll close the poll then. All right, we're gonna close the poll. So if you haven't voted yet, last 2 seconds. Okay, ending the poll now.
Great. So the reason that we're asking this is because tracking referrals in the context of social determinants of health is a really great way to bolster how you measure success. So it looks like the vast majority is documenting internal and external referrals in structured EHR fields, which is excellent. Obviously, if you're not documenting this at all, it's impossible to tell from a data analytics perspective how many of your patients you are sending to community resources. And it doesn't even necessarily have to be an external referral. It could be within your own community health center. Are you sending somebody to a diabetic education group? Are you sending them to see a specific nurse case manager? It's really up to you and the workflow that you have implemented at your center. But if you have it documented in a structured way, then you can start to apply the SDOH filters, and you can start to see, am I actually referring patients who have certain SDOH factors for referrals, and then you can start to group them and track those patients who have gone to those referrals. So we're going to talk about that in the last few minutes here. And I did want to make a note that 46 centers across Chicanes have the referrals module in CPCI. So like the SDOH module, which is additional to your core implementation when you went live, referrals is an additional cost and an additional implementation, but it's probably one of our most popular because it gives you access to tracking patients and where they are in the referral cycle. So you get access to registries and reports. You also get that on the patient visit planning report, so you can start to marry that with the social determinants of health data to see how you're actually managing these patients. So if you think about enabling services, do you have a food bank that you always send patients to? Do you have an employment and housing education service that you send patients to? Do you have programs within your health center that you refer patients to as an internal referral? And, you know, the age-old question that we always ask when I refer them there, does that actually do anything? Does it help them have better health outcomes? And having this data available helps you answer that question. So a key way that you can do that is through something called cohorts, which I think is an incredibly powerful feature of CPCI that not a ton of people use just because they're not as familiar with them. So what it is defining a group of people who share common characteristics. You can define that in CPCI itself in a number of different ways, and we're not going to go into huge depth how to actually create cohorts. We actually have a user guide that talks about how to create cohorts in CPCI that will walk you through step by step, and we have a number of webinars that discuss it. But I did want to definitely mention it, that if you're interested in tracking a specific group of patients and how they do in terms of their health outcomes overall, cohorts are an excellent way to do that. So there's two different types. There's static cohort, which is essentially you're looking at data in CPCI, you're filtering, you're creating a patient list, and then you're marking that as a cohort. That cohort consists of all the patients that you've defined, and that's it. No patients go in and out of that cohort. It's just those that you've defined. A dynamic cohort is a set of conditions that we write a code for that pulls information over from your EHR that says all patients who meet X criteria are going to be considered part of my cohort. So it updates depending on patients who fall in and out of those criteria. The dynamic cohorts are an extra charge because we need to set that up. However, static cohorts you can do right now if you want. You could log into CPCI and create one based off of a registry or the detail list of a measure. So the manual way to do it is you either filter within CPCI to create it, or you can even upload a list of MRNs. So if you have a program that you're currently doing where you track that in a spreadsheet, you can upload that list and then have that cohort available for you right away. So applying that cohort, an example could be if we're again looking at the diabetes A1C greater than 9 or untested measure, this is a good example to explain how cohorts work, just because it's one of the most common ones we see. So let's say you wanted to create a cohort of patients whose A1C was greater than 9 or untested. I could go to the detail list of this measure. So I've gone from the measure analyzer to the detail list. And then I'm going to filter everybody who's in the numerator. So everybody who meets the criteria of A1C greater than 9 or untested. And then I'm going to click this little cohort button. It looks kind of like 3 people standing all together. And then it's going to pop up and say create cohort. I'm going to explain what I want to do, what I've filtered to in my detail list. I'm going to click create cohort. And then I'm going to have that cohort that I can then filter on any report, registry, measure analyzer. I can filter it on the PVP. And if we think about what we did here, obviously it's 100% at the top of this measure analyzer page because I'm only filtering on patients who had an A1C greater than 9 or untested. But going forward, I can track how they do over time. Am I improving their A1C based on those who were out of control or untested at a certain point in time? You can apply this to a scorecard. So you could see how am I performing on a number of other measures for this particular cohort that I've just created of uncontrolled or untested diabetics. And then you can also apply it to the PVP, and you will also see a flag if you create any cohorts and any patients come in and show up on the PVP on any given day. If they're in a cohort, it will tell you on the PVP. So that is a nice way, too, of kind of alerting support staff or whoever is running the PVP that, oh, they're in a cohort that you care about. This is important. So if we take that cohort idea and carry it forward into the, for example, patients with primary care encounters, we could create a cohort of patients who have had their social needs assessment done. So there's a measure, social determinants of health assessment, or you could use the registry and say, I want to see everybody who has had one done, or maybe I want to see everybody who hasn't had one done, and start to apply that to different reports to see where are my gaps. Are there patients who have come in that I should have given an assessment to, or patients that came in that I did give an assessment to, how are they doing on A1C greater than 9 or untested? So there's a lot of different ways that you can apply it, and it's a really powerful tool, again, for tracking those specific groups of patients over time. You can also use it to apply a cohort filter to the referrals report. So for all of you who have the referrals module and are using it, definitely take a look at cohorts to see how you can use that to evaluate how you're doing on referrals and particularly closing the loop on referrals. So if you have a cohort of patients that you're very concerned about and all of them have open referrals still, that's a really good place to start for, well, I want to close out some of these referrals and get in touch with these patients. So really quickly, we've done a number of things to improve the features of our SDOH module, including the dashboards. We also have a social needs all patients dashboard that we're creating a couple fixes to right now, but that is even for people who don't have the social determinants of health module. And then future needs, we're going to be creating new alerts. We're going to be adding more SDOH criteria, changing the weightings of some of them, and just continuing to build out our product features. And for those of you who are using SDOH assessment tools a lot and you're already doing some analysis, whether it be in CPCI or somewhere else, we would love to hear from you because we know this is important. We know a lot of people are interested in it, and we want to keep making these tools better. So please don't hesitate to get in touch. These are just some of the resources we used. And now I know we were originally going to have a little bit more time for questions. I think there was a lot more information to share here, but I would love to open up the line for questions if there are any.
Thank you very much, Emily. We have unmuted participants. If you would like to ask a question, please say your name and we'll be happy to answer it. We have about 5 minutes for questions. If you prefer to chat in your question, that's also an option. Okay. There was a lot of good information shared, so definitely don't hesitate to contact us. After the post-webinar, we will send out the copy of this presentation and a recording for all participants. We definitely want to encourage, questions right now. So we'll give another minute or so. And Emily, is there anything that you would like to? Oh, we do have a question. Has Azara mapped data from Health Leads Assessment Tool?
Health Leads Assessment Tool, is that particular to a specific EHR?
No, I believe it's a standard tool that it's kind of like its own, similar to Prepared as certain domains. Have you guys worked with a health center in New York or elsewhere? Mm-hmm.
Yeah, that's a great question. I will check. I have not worked with a health center personally who's used that assessment tool, but as long as it is, again, sort of lines up roughly with the Prepare questions, we can absolutely map it. So it doesn't even need to be that we've done it in the past. As long as we can identify that this is asking about food, this is asking about transport, that's absolutely possible.
Great. Okay, awesome. And we're just going to remind participants that there will be an evaluation. We're actually going to share that now in the chat area for you guys to let us know your input about this 2 webinars, the one from last week and today. And you're welcome to add, what you would like to see next. We want to hear from you. We know that everyone is digitally working on social determinants, so getting your input on what materials or topics will be useful for webinars in 2020, it's helpful for us, and any feedback from today is greatly appreciated. So without further ado, I think we do have just 2 more minutes back to your time. We really want to thank everyone. We're going to stay on the line if anyone has questions, but this concludes today's webinar. Thank you very much for your participation.
Thank you, everyone.
Bye.
Emily, I would like to just thank you again for today's presentation. We really appreciate it. It's 2 p.m., so we're going to end the meeting now. Thank you.
Great. Thank you so much. Let me know if there's any questions in the meantime.
Will do. Have a great one.
Thanks.